Welcome to Raaonline. So today we have a very important trial for exam. It's called as Proseva Trail. Okay. So definitely you'll be given one respiratory case for your exam, especially in your Viva, in your practicals, right? So if you answer well, slowly they will escalate the severity of the case, leading to endotracheal intubation. And still in endotracheal intubation, if the patient is not able to get proper oxygenation, they'll ask about the proning. Right? So if they ask about proning, definitely they will ask you about this kind of Proseva Trail. Okay. So look at this image, dear friends. In this image, the heart is present anteriorly, right, at the top, maybe so upper, you can use the in the upper line. And here it is at the bottom. Okay. This is nothing but this is supination and this is pronation. So Proseva Trail. Prone positioning in severe acute respiratory distress syndrome in NEJM 2013. So whenever we talk about trial, you need to think yourself whether this is going to be clinically relevant for your management. And what is the characteristic features of the patients taken in this particular study? Will that match your clinical relevant patient in your hospital? Only then the summary or the conclusion can be applied to your patient, right? So the baseline characteristic should be the same as what you see in your department. Only then the conclusion or the outcome of this particular trial can be applied to your patients. Okay. So starting with the clinical question, does the early application of prone positioning improve mortality in severe ARDS? Very important line, dear friends. They have written as early application because in previous trials, a late application did not prove much benefits. And moreover, they have specifically written severe ARDS. Because again in previous trials, in the early ARDS or moderate ARDS, prone positioning did not perform better. So this question is very clear. Early application, severe ARDS, mortality benefits. Okay. So does the early application of prone positioning improve mortality in severe ARDS? Okay. So background, there is no positive previous trials to tell there are mortality benefits in proning overall, because they conducted on general ARDS and they didn't group the patients as severe ARDS in the first place. Okay, and the timing to prone also was various. And moreover, we know that proning improved oxygenation in the previous trials. And we know that proning prevented ventilator-induced lung injuries as well. So when oxygenation is getting improved and lung injury is getting improved, why can't the mortality benefits be? Right? So that's a valid question. So they proceeded with this particular trial. So ARDS by definition from American European Consensus Conference, endotracheal intubation, mechanical ventilation for ARDS for less than 36 hours and severe ARDS defined as PaO2 FiO2 ratio less than 150 mmHg, in FiO2 of more than 0.6, a PEEP of more than 5 cm of water and a tidal volume of about 6 ml per kg of predicted body weight. Okay. The criteria were confirmed in this particular trial after 12 to 24 hours of mechanical ventilation. So this is a multicentric trial. So whenever we discuss about a multicentric trial, it has more gravity to it. Okay. The bias can be much limited. Okay. Prospective randomized control trial, and the stratification is done in the ICU by computer generated stuff. And blinding of the outcome assessors. Okay, people who are collecting the data, they know what kind of strategy is being followed because they know the patient is prone or supine, right? So people who are collecting the data will know about particular treatment strategy undergoing, but people who are assessors, outcome assessors, they are blinded from this particular treatment strategy. Okay, so that kind of bias is actually avoided. Okay, consent. Why I have specifically written consent is if you read that Proseva trial, it's mentioned that patients who are extremely sick or difficult to consent, the consent is actually applied from next of the kin. And during the study, at any point of time, if the patient is woken up and they are conscious enough with good muscle power to consent for the particular study, consent was obtained from the patients as well. Okay, so such is the significance of getting a consent, dear friends. It's not that just because the next kin has signed, right? If the patient is able to sign, you need to get consent from the patient as well. Okay. So this was done in 26 centers in France and 1 center in Spain. So totally 27 centers. all with more than 5 years of experience of proning. Okay, that's very, very important, right? If at all the team doesn't know how to prone, then the technique itself is going to be a faulty technique, right? So these ICUs are good in performing proning with an experience of more than 5 years. This study was conducted from 2008 to 2011, and the population under study is adult patient with severe ARDS who are intubated, ventilated, and tried all the stabilizing strategy in less than 36 hours of inclusion, and with the set criteria of severe ARDS, that is PaO2 by FaO2 is less than 150, with FaO2 of more than 0.6, with PEEP more than or equal to 5, with tidal volume of around 6 ml per kg, which is confirmed after 12 to 24 hours of ventilation. Okay, and people who are contraindicated from proning are basically excluded. Okay, so 474 patients randomized from nearly 3,449 patients who were actually screened for ARDS. They got only 474 inclusion patients. So what type of intervention? So proning was done. Prone was at least for 16 consecutive hours for 28 days or until improvement to set a standard. Okay, so every patient was started with volume controlled ventilation, 6 ml per kg of tidal volume. The idea is to maintain the P plat to less than 30 with the pH more than 7.2. Okay, control patients were in the supine position, semi-recommended position. Okay, so criteria was stopping prone treatment in patients in the prone segment. So now we have two different teams. One team is a control team where only supination is followed, and one team is the prone team. Okay, so in the prone team, they are going to prone the patient for minimum 16 continuous consecutive hours, and they are going to supine. Okay, they are going to watch for an improvement, and they are going to check for criteria for reproning, and they are going to prone again. So this kind of proning and supination, they are going to stop at one point of time. The criteria for stopping this kind of proning is improvement in oxygenation, right? Defined as PaO2 to FaO2 ratio of more than 150 mmHg with a PEEP of less than 10 centimeter of water and an FaO2 of less than 0.6 in the prone group. So these criteria had to be met in the supine position for at least 4 hours at the end of the last prone session. Okay, so this patient was prone and then supine, and after supination, you're checking the patient for at least 4 hours, and in this 4 hours, the FaO2 requirement has come down significantly, PaO2 to FaO2 ratio has improved significantly. Okay, then you need not prone again. Okay, a decrease in the PaO2 to FaO2 ratio of more than 20% relative to the ratio in the supine position. Okay, so if at all your proning is worsening the situation, do not prone. Okay, and complications occurring during a proning session are leading to its immediate interruption, everything was stopped. So what are such complications which is interrupting your proning of this patient? Non-scheduled extubations, accidental extubations basically, mainstem bronchus intubations, endotracheal tube obstruction, hemoptysis, cardiac arrest, bradycardia, heart rate less than 30 beats, it's sustaining for more than 1 minute, systolic BP going less than 60 mmHg for more than 5 minutes after your active resuscitation, and any other life-threatening reason for which the clinician decided to stop the treatment of proning. Okay, so let's look at the Consort diagram. The Consort diagram will tell you how many people were actually screened, included, excluded, randomized, and then analyzed for outcome. So 51,189 patients were admitted in 27 ICUs under study from Jan 1, 2008 to July 25, 2011. Okay, among this 51,000 people, 47,740 did not have ARDS in the first place, right? So we are left with only 3,449 patients with ARDS. Okay, among them 2,015 were not screened. So my first question as a reader comes to me that why 2,000 people were not screened? Is it because of some selective bias? Will this influence the outcome? I really don't know, right? So this is a point in this particular trial to be kept in mind. Really 2,000 people, okay, almost more than half, man. 3,449 had ARDS. Out of this, more than half, more than 60% were not screened at all, right? So we don't know, this could be because of a selection bias. We need to be very cautious in this study. And 1,434 were actually screened, 858 were not eligible because of exclusion criteria, and 576 were actually eligible. So among this 576 eligible, 102 were excluded because of 37 had improved symptoms after 12 to 24 hours, 55 had organizational problems in the study center, 10 were withdrawn by the physician, and the previous other people withdrew consent, they didn't give consent and stuff. Okay, Left with 474 underwent randomization, 234 assigned to supine group, 240 assigned to the prawn group. Okay. So 234 with the supine and 240 in your treatment intervention group, right? So among the 234, 5 were excluded. 3 had PF ratio more than 150, 1 was enrolled before 12-hour stabilization period, and 1 had guardianship issues as well. So in your intervention group, 3 were excluded, among which the 2 were enrolled before 12 hours and 1 received NIV for more than 24 hours. Okay. So 466 were included in the intention to treat analysis. Okay. 229 were in supine group, 237 was the intervention group. Okay. 466 were included in the 90-day follow-up as well. Okay. And not only the 28-day mortality, they are going to check for 90 days mortality follow-up as well. Okay. 229 were in supine group and 237 were in the intervention group. Outcome. Primary outcome is all-cause mortality at 28 days. Okay. So if you see, 16% is the mortality rate in patient who underwent prawning, and 32% is almost double in patient who are left supine. Okay, and the P ratio is very, very significant. Okay, so adjusted odds ratio is also 0.42%, right? So this shows that your early proning in severe ARDS can bring down mortality significantly, because in proning it's only 16% and the supination group is 32.8%. Okay, and no increase in adverse events in the proning group as well. Secondary endpoints. If I read this paper, dear friends, if at all I get a mortality benefit as a primary outcome, then I am not worried much about the secondary endpoints at all, right? For example, if the patient is going to stay for 5 more days in the hospital, or the patient is getting 1 more episode of a lung infection and stuff, it's completely okay. Having said that, my mortality benefit is very high, right? So I'm not very keen in this kind of secondary endpoints, of course, but if the secondary endpoints is pushing my patient towards physical dependence, extreme physical dependence or complete vegetative state, then that is going to be very significant, right? So in this trial, secondary endpoints were mortality at day 90, rate of successful extubation, time to successful extubation, length of stay in the hospital, in the ICU, complications, use of non-invasive ventilation, tracheotomy rate, right? So again, let me underline and highlight the fact that if I'm getting a mortality benefit, I'm okay in getting my patient tracheostomized, I'm okay if a patient uses a NIV, I'm okay for a little more days in ICU stay, or a little more days with intubation as well, right? So the expected 28-day mortality in the supine group for otherwise also, it's around 60%, okay? So team estimated that with a sample of around 456 patients, the study will have a 90% power to detect an absolute reduction of 15% points with proning position at a one-sided type 1 error rate of 5%. Okay, we'll tell you how to calculate the statistics sample size in a different presentation as well. Okay, so the point to consider is that when they started this Proseva trial, patients who were left in the supine position, they had a 28-day mortality of 60%, right? So now, do you remember in our trial, patients who were in the supination, the mortality rate was only 32%, right? So how come in this particular trial, compared to the general population, compared to the other hospitals, from 60% mortality, how did they bring down to 32% mortality in supine group? Of course, proning decreases to 16%, but my question is, how did a 60% mortality rate come down to 32%? I really don't know about it. So that is a flaw in this particular trial. It could be maybe due to that these are well experienced hospital with a more than 5 years experience in proning, and the standard is well set, right? So because of all these reasons, they could have brought the general expected 28-day mortality from 60% to 32% on the first place. Okay. So now we need to compare the baseline characteristics. So you can freeze the slide and you can go through and check whether these two groups are evenly distributed. Okay. Age is somewhere around 60 to 58. Male sex is 66 to 70%, and ICU is around 3.9 to 4. Okay. And MEC score is also uniform. Diabetes a little bit higher in the prone group. Renal failure is less. Hepatic disease is less in the prone group. CAD is almost equal, and immunodepression like cancer is almost 13 and 24. Okay. Immunodeficiency is 16%, which is 13% here. And vasopressor used more in the supine group. Neuromuscular blocker is less. Renal replacement therapy is around 17%. Glucocorticoids use is also okay. So it's okay to get managed like this, right? So coming to the ventilator settings, so it is 381 plus or minus 66 and 384 almost the same. Tidal volume we targeted around 6 ml per kg of predicted body weight, and respiratory frequency somewhere near 27 plus or minus 5, and the PEEP is somewhere around 10 to 15. FiO2 requirement is okay, and PEEP active as well maintained, right? So almost it's maintained. Coming to the outcome. So primary and secondary outcome, we know that at 28 day not adjusted, it's around 75, that is 32.8%, 32.8%, here's only 16%, okay, with a significant p-value, okay. Even at day 90, okay, so 41% is the mortality in supine group, whereas 23% in the prone group, okay, with a significant p-value as well, okay. And of course, the successful extubation rates are 65 here and 80% in prone group. That's also is better, right? And length of ICU stay is almost the same, and ventilator free days are actually better in your proning group, okay. Pneumothorax is actually more in your proning group, okay. This is a Kaplan-Meier plot curve, okay. This tells you the days and cumulative probability of survival. The chances of survival is actually better in the proning group, okay. So this tells you that there is mortality benefits, okay. So the authors of this trial concluded that patients with severe ARDS have improved mortality benefits with early and long proning section, that's minimum 16 hours. So what are the strengths and weakness of this particular trial? Standardized ventilation and weaning strategy with the use of PEEP FiO2 table, okay. So you need to have a standardized approach to address this kind of issues, right? So possibly because of this kind of standardized approach, they were able to bring down the general mortality of supine patients from 60% to 32%, right? But if you can properly do it in a proning person, then you can bring down the 32% also to 16%, okay. An appropriate power calculation and intention to treat analysis. We already know that intention to treat analysis is literally your real-time situation analysis, right? Weakness is, as I already said you, nearly 60% of the patients, like 2015 patients, were not screened for inclusion in this trial. We really don't know whether it's a selection bias, right? And some differences in the baseline characteristics comparing to proning to supine position is that SOFA score was somewhere like, okay, 10.4 to 9.6. Use of vasopressors were 83% in the supine group. Neuromuscular was 91% in the other group. Can this tell something about the severity of illnesses, right? SOFA score is 10.4, is more severe in the supine group, right? And vasopressors, the hemodynamic instability was more in the vasopressor, in the supine group. And complete or better neuromuscular blockade paralysis are achieved in the proning group, right? Have these things influenced the study and the outcome? We really don't know, right? And of course, centers all had more than 5 years of proning experience, right? So only if your center also has such kind of good proning experience and good strategy for ventilating such patients, you can get this kind of results in your hospital, right? So this is for a well-experienced centers only. You cannot apply this in a non-experienced center or fresh centers. So take-home message from this Proseva trial is that proning in severe ARDS reduces mortality without an increase in adverse outcomes, but further studies are required to confirm these findings. But in the meantime, these results are difficult to ignore and you can take up in your real-time situation, okay. So when asked about Proseva trial, you need to tell about which journal, which year, okay, and possibly which country started with it. You need to mention about the multi-centric trial, a prospective randomized control trial, and how was randomization done, right, and how it started and how many patients roughly was involved in both the groups, right. Even if you don't get the specific number, a rough number is more than enough to tell this was in the supine group and this was in the prone position ventilation. And you need to tell what is the intervention exactly. Okay, proning was continued for 16 consecutive hours, okay, for minimum of 28 days or even more if they show some benefits, okay. So what are the reasons proning was interrupted, what are the complications expected, and what was the primary outcome, what was the secondary outcome, and what did the study tell you. Not only that, you need to tell about the strength of the particular study and what is the weakness of the study. And finally, they will ask you a question, dear friends. Whenever you discuss about trials, finally, they will ask you this one question, whether you will use this trial outcome findings in your clinical practice. Okay, that will be your final question to be answered. Okay, so you can tell that the clinical characteristics features is almost resembling my group of patients, right? And this kind of technique can be performed in my hospital. I have adequate facilities to be for these things to be performed in my hospital. For all these reasons, I would proceed to do proning for my patient in case of severe ARDS, right? So this is what your answer should be. Thank you.